Good evening, everybody. Welcome to another edition of Hand in Focus. The theme of tonight's journal club is Wrist Arthritis. My name is Harvey Chim from the University of Florida, and I'll be co-moderating this session with Eberlin from MGH. We have two great papers tonight. First, Dr. Ilvy will be joining us and talking about her paper, Outcomes of Darrach and Sauvé-Kapandji Procedures, a Systematic Review. Next, we have Dr. Charles Dane, who's talking to us tonight about his paper, Long-Term Oral Steroid Use, a Unique Risk Factor in Four-Corner Fusion Compared with Other Wrist Salvage Operations. Our expert tonight is Dr. Brian Adams. He's an emeritus professor of surgery, orthopedic surgery at Baylor College of Medicine, and past president of the AHS, and an expert in wrist arthritis and all things around the wrist. So we're very privileged to have him join us tonight. So the format for tonight's journal club will be as for previous editions. We'll have the authors start us off with a presentation about their paper. Subsequently, we have residents from MUSC to discuss the articles and how it will affect their new practice. Tonight, we have Drs. Michael Orton and Charles Johnson joining us. This will be followed by expert discussion and then open Q&A. So again, as in the previous editions of Hand in Focus, please ask questions because we really want to hear from you, the audience, and we want to make sure this is an educational experience. This session is designed to be engaging and interactive. So without further ado, I'd like to invite Dr. Cotterell to talk to us about our paper. Ilvy, please.
All right, I think you need to, yeah. All right, good evening, everyone. Let's see here. Thank you for allowing me to present our paper and making me part of this. So arthritis of the distal radial ulnar joint. It's been a clinical challenge for hand surgeons for many years and probably many more years to come. And traditionally, removing the distal ulnar, the ulnar head, called a Darrach procedure, coined by William or popularized by William Darrach in 1912, was the only option. But stump instability, impingement, convergence, ulnar carpal translation, and ultimately the one bone, the dreaded one bone forearm could be a result of this procedure. So stabilization procedures were added to use the ECU and other supporting soft tissue structures to help with stabilization of the distal ulnar stump, but still that didn't solve all problems either. Sauvé-Kapandji in 1936 described a procedure, an alternative procedure, where they fused the distal radial ulnar joint and then osteotomized it proximal to that fusion to create a pseudoarthrosis, permitting rotation of the forearm through that. While that helped with the more obvious issues such as ulnar carpal translation, and excuse that x-ray, I just couldn't find another one, but by stabilizing the ulnar support structures, it did not help with stabilizing the ulnar stump and also led to stump instability, impingement, and convergence. So does age matter? What I historically was taught was you do a PRC in older low demand people, you do a four corner fusion in younger people, you do an LRTI on older low demand people, you do a CMC arthrodesis maybe in the more active young laborer. And even the treatment of distal radius fractures in the elderly has had that stigma of maybe not do less in people that are older. But how old is too older? What does it mean to be old? When is it too old to a nightclub, be the president, have a baby? So my mom and all of her golf posse there in their mid 70s to late 80s would not say that they are low demand people. They are active young ladies, maybe more so than this guy. So that sparked a discussion in our fellowship. I always like to kind of lead, like this is why an article was picked or that's why we decided to look into this. So a resident said, well, obviously this person's low demand, they get a Darrach and this one's high demand. And we challenged that. So we decided to look it up and we screened 103 articles, 44 of which met our inclusion criteria. And we looked at the outcomes. We had some challenges with common outcome measures and grading scales across all the different articles. But what we found was that in the patients that underwent a Darrach and a Sauvé-Kapandji, there were very similar outcomes in the quick dash scores, grip strength, range of motion, and overall patient satisfaction. There was like no difference between any of those outcomes measures, regardless of why they underwent the procedure, OA versus RA, or how old those people were. What we did find was that the mechanical symptoms were slightly higher in the Darrach group, 12 versus 7%, and higher complications or reoperations in the Sauvé-Kapandji group, although some studies did include elective screw removal as part of a reoperation. Some interesting findings were that stump instability actually did not correlate with patient satisfaction, but many different techniques to address the stump instability were included. The weaknesses were that we, again, included all comers, OA, RA, post-traumatic, all ages. And as we know, rheumatoid arthritis has had multiple, improvements or advances in the years, so that may have led to some changes. And then there's also a large surgeon bias. And in Europe, there may be more people leaning towards the Sauvé-Kapandji versus in the US. And then again, like I said before, the outcomes measured were inconsistently reported. Are you satisfied with this procedure? Yes or no. Would you have this procedure again? Yes or no. Would you rate it on a scale of 1 to 5? The different papers had different outcomes measures. And then due to these limitations in the data, we were unable to do statistic analysis. But what we found was the conventional wisdom that a younger, active, more labor type person needs a Sauvé-Kapandji or restores better function and has less complications despite the increased technical difficulty. So I want to thank, first of all, my co-author, Jonathan Isaacs, who's not here, but also one of my mentors that led me to go into hand surgery, Dr. Bill Bowers, also an expert in the DREJ. So thank you.
Great. Thank you so much, Ilvy. That was great. Could I please invite Dr. Michael Orton next to talk to us about this paper?
Hey, thanks for having me. Yeah, I think for this paper, and kind of as was pointed out in this paper, there's been some mixed data regarding the use of steroids, whether that's oral or by injection, and what risks that may impose on this patient population. Interestingly, in this paper, of the 4 different groups that they studied, patients undergoing 4-corner fusion were at an increased risk of surgical site complication.
Oh, I'm sorry to interrupt, Michael, but I just want to clarify that we're talking about the DRUJ paper.
I suppose I've got the I've got the paper here by Dr. Charles Daly here. Yeah. So,
no worries.
Sorry. So for the DRUJ paper, apologies for that. Quick dash scores were similar for and below the threshold of clinical importance for kind of all these patient groups. So they did remain comparable. I thought that it was one of my main takeaways here was that the evolving techniques, improved hardware and instrumentation may have reduced the frequency of historically common complications. I think it's basically an important paper where impingement is going to remain a problem for both of these type of procedures and kind of changes the way we think about how we should be taking care of wrist arthritis.
That's great. Thank you so much. Next, I'd like to invite Dr. Brian Adams, our expert, to share his pearls of wisdom for DREJ arthritis. Brian, please.
All right, I have to get to my screen here. To exit for, oh shoot, okay, there we go. Are we seeing it?
Yep, we see it.
Okay.
Yep.
Well, I think DREJ has been one of my favorite topics. In fact, that's how I got started in my academic interest. And very interesting that you showed Bill Bowers' picture. Bill was also a friend of mine, and I never forget when he walked. I was program chair for the Hand Society, and he walked down the aisle, and after this one session, and he came up to me, he says, "Brian, I am tired of writing the Greens chapter on DRUJ. I want you to take over for me. And I was, thrilled and honored to do it. Then he gave me his entire pile of stuff about 2 weeks later, and it filled a whole box. And it was one of the biggest tasks I've ever tried to do to get through it all. So, but anyway, that's how I got further launched into the drudgery of hand surgery at the DRUJ. I think this article actually highlights really where a lot of people struggle with the distal radial ulnar joint and what to do with it. And every meeting has a lot of discussion. There's a lot of bias for sure. Many people are driven by their mentors. People tend to really pontificate about it. But I think this sort of paper really helps us put it in perspective to really look at it critically. I would say one thing that I thought sort of contradicted your presentation, your paper, because I was really taken by the first full paragraph on page 3, and where you go through who the patients are that are most satisfied. And I think this does fit with more traditional thinking, and that is the highest satisfaction group consisted of patients with RA stabilized after DRUJ, 93%. And the least satisfied were SK in patients without RA. So here we're talking about very low demand patients, typically, if you do it statistically, that are RA, and they tolerate a lot. Their pain tolerance over the years, they've learned to tolerate things. Versus those that you highlighted, those that have an SK tend to be more on the active side. And if you didn't get it right, you didn't stabilize it, they didn't like it very much. At least that's what I got out of it. You had a much higher unsatisfaction rate. So that was my take on your great article review. When I look at the DRUJ, I think a lot of factors. This is really a soft tissue procedure when you think about the distal radial ulnar joint. It's not really a bony procedure, and all of these little balls you have to balance out in thinking about how you're going to handle a particular patient. Because although it's good to say that they're equal, it's outliers that always sort of get in our way. So it's that 10% that don't always do well with whatever procedure you like. And that's what you're really trying to narrow it down. In today's world, I don't think we necessarily focus directly on the DRUJ as much as we think of it as an ulnar column. And we certainly know this based on all the distal radial ulnar, all the distal radius fracture literature, and the problem still remains at the ulnar column for so much of the persistent problems. Particularly the older patient, again, you mentioned, that might need a Darrach, or somebody with post-traumatic arthritis that might get an SK. So it's rarely in isolation that we're considering what to do about the DRUJ. There's almost always something else going on, especially if it's post-traumatic. So I would behoove you to really think about this as an ulnar column problem. And certainly that started off, as you're all familiar with the distal oblique band, we started to really focus in on other things. To really look at it as a whole, if you will, not just in that one small focused area. In my practice, I don't think you can isolate down to one option. I think you have to consider all of these options I have listed here, and I would still venture to say they all have a place in your armamentarium when you're treating these kind of patients. And I would suggest to you that you kind of go through these. We don't have time tonight, but maybe in a discussion we can talk about it. But the food for thought is that, to me, when I talk about with the patient to choose the option, is the first and foremost, tell them that there's no perfect solution. We know that they're going to have some sort of problems persistent. It's just that kind of a joint. We've already mentioned age and activity is very influential on the outcome. I think that's true. The cause why you're there really limits or drives your options. In other words, you may not be able to choose a Sauvé-Kapandji, for instance, if the ulnar head is mostly eroded away. That just becomes, limitation. And so you're driven to, if amongst those two, a Darrach. So each one of these options has their own nuances. And so I would really highlight, don't limit your skill set to one option. You tend to, out of your fellowship, go with what's what you've been taught, or maybe, what you've read, but keep all the options open. Don't be driven by one. And I keep coming back to the last thing is, this is really about management of soft tissues. And your paper highlights that, is that we know impingement is always a problem. So if we look at the treatment options back again, each one of these has their own sort of drawbacks, all the way from joint debridement, which I think works well in a younger patient, post-traumatic. Don't surprise yourself sometime by just doing sometimes a joint debridement, which doesn't work in most joints. Ulnar shortening osteotomy, where you can change the articular surface. We know it works in multiple joints, even the CMC of the thumb. You've already read about the Sauvé-Kapandji. When I grew up, the main reason to consider that was to prevent ulnar translation of the carpus. And I still think that that's one of the main indications. In Europe, it's a very popular procedure. I like the hemi-resection arthroplasty a la Bill Bowers. I simplified it. You can read in greens. Darrach procedure you discussed. And then implant arthroplasty, which I think has a role. So what are the influencers? And that's today's world. We have to have influencers on everything we do. DRUJ stability is still, I think, key. So if you go in with DRUJ instability, you're going to come out with DRUJ instability. If you do a Darrach and you're going to make it worse, and some of the other options, even a hemi-resection interposition, you're going to get a worse outcome. Age and activity, we've already highlighted. The older they are, the less active they are, the more tolerant they're going to be. Disease, I mentioned, it's not just rheumatoid, but it's other ones. And think about whether or not they have a distal radius malunion. That's going to really affect it. And ulnar translation, some of the older articles really highlighted this. If you take somebody with carpal translation and do a Darrach, it can be a disaster. And those are the patients that tend not to get very good grip strength back. And then last, but don't forget about it. What if what you did fails? What are you going to do next? Are you going to do an aptus? Are you going to do an implant of some sort? What are you going to do? Are you going to do the interposition that more recently Sateriano's popularized? I think you have to have something in your back pocket, because as I started off, it's not a perfect operation no matter which one you choose. So those are the things I learned over the years the hard way. I would like to just present very quickly a case. Some of you have seen this because I presented it. This young lady who is a OBGYN resident presented with this. I want you to look at that. It was DRUJ is obviously unstable. Here's her CT scan showing it basically dislocated, nearly subluxated. And then she was fixed with a screw to TF of the styloid, as well as pin the radius to the ulna to the radius, stabilized it. The pins were removed, and you can see the ulna is again dislocated. It was at this point that she presented to me, and she was offered a Bowers. She was offered a Darrach. She was offered a hemi-resection interposition, and she was offered an aptus by 3 different hand surgeons. All very good surgeons, all good choices, options. She came to me because she knew that if she had any of those operations, she'd have to drop out of her residency. She no longer could supinate, and she really wanted to go into OBGYN, so she couldn't catch babies. So here she is when she presented to me. You can see a little bit of arthritic changes in the DRUJ, a little bit of ulnar positive variance, but not terrible. And again, a dislocated joint. So what would you do for this patient? Well, if you really want to know, I think this applies to anybody that's a younger crowd where you're not sure and they have post-traumatic changes. Compare to the other side. Don't forget to do that. We talk about it a lot, but you really need to consider that. So here's the one comparison view. Here's the oblique. Here's the true lateral here. Again, you're seeing the subluxation dorsally. Here's the forearm. Don't be fooled by any DRUJ problem, especially if it's been around for a while, that it might be a more proximal concern, which you all know to look for. And here's the lateral again, showing it. And we can see that the forearm otherwise looks pretty good. So what do we do here? I just wanted to highlight this. Again, this is a DRUJ arthritic problem, subluxation along with it. Arthritis is mild, been offered all those solutions we just discussed. And yet when I saw her, I said, you know, we have a problem that's not related necessarily to that. If we do any of those solutions, Darrach, SK, or even try one implant, we're going to have the same problem again. And you can see the plastic deformation of the ulna, which is very rare. But Paul Dell actually, Harvey, actually described this many years ago before your time. And he recommended ulnar osteotomy. And I'll never forget when he presented that at the hand meeting. And so that's what I did here. And she is now back to residency, just completed 1 year to go and doing fantastic. So I like to show this case because sometimes we think about ablation, Darrach in younger patients, but there might be other options. Thank you.
Thank you so much, Brian. That was really great, and that's a great case to share. So thank you again. You know, I'd like to start off the discussion. You know, something you mentioned about how SK was first described to prevent ulnar translocation of the carpus. That's one of the classic indications for SK. But there have also been studies that show that it actually doesn't prevent established translocation of the carpus. So I'd like to ask you, Brian, and maybe the rest of the panel as well, what exactly are your indications that you consider an SK? Is it if you see the lunate a little bit translocated ulnarly, or what definitions will you define that you do an SK for?
Well, in Europe, the opinions would be that any slight ulnar translation as compared to the opposite side would be an indication. I think where I was trained and what I believed in is if it was an RA patient that was not under good control like they are today with the DMARDs and so forth. So the indications have probably dropped in terms of the RA patient being helped in not having further ulnar translation. And there's actually a technique when it's even eroded that some of you might have seen by the Japanese where they turn the ulnar head. And so they put the neck into the hole in the side of the distal radius and it supports it and it actually maintains the soft tissue connections. And that's worked beautifully. Obviously, the other option of that, if you see it, is to do a radial lunate fusion, which is probably even more effective than a Sauvé-Kapandji procedure in an RA patient. So I think you're right. You're highlighting is where's this little nuance where SK is going to help you. And it would be in somebody in a non-RA that shows not complete ulnar translation, but early ulnar translation as compared to the opposite side. That would probably be the classic description of where it might be beneficial versus some of the other options.
Yeah, I think those like wet rheumatoids that are just very uncontrolled, where the soft tissue envelope is just really not there. Although again, some of them do very well after a Darrach, but the reason that I included an X-ray of a post-proximal row carpectomy with ulnar translations because I couldn't find anything, and just DRUJ with ulnar translation. And that was a patient that had been referred to me after a PRC where I think they had gone to town a little bit too much for the RSC ligament and created that instability. So yeah, I think just putting like doing a fusion there as opposed to addressing the reason why there's ulnar carpal translation isn't necessarily enough.
Yeah, and one of the drawbacks of doing an SK in somebody with erosion in a rheumatoid, and that's why I brought up the one from the Japanese, is that if you close down the DRUJ in order to get to raw bone and there's already some erosion, you haven't necessarily helped yourself and you might hurt them. Now they might get stylocarpal impingement, and you have to be careful of that. So it was also taught that then you recess the ulnar head more proximally. Well, if you do that, are you really supporting the carpus and are you defeating the purpose of doing an SK? So I think it is a technical operation. When I wrote the last time when I wrote it, now Fraser Leversedge is taking it over, I mentioned at least some of the tricks and pearls on how to do an SK so that you can manage it, because it can be a tricky operation if you end up with a pretty mobile distal ulnar head.
So, you know, those are really great technical posts, Brian, but let me ask you a little bit more about the specifics of how you do an SK, because as we know, the rate of fusion and the outcomes are so important. So for myself, I try and do the resection as distal as possible. to prevent proximal impingement of the forearm bones. And I use two canceller screws for compression. Is that how you do it as well? Or do you have some other method to do it that you think works very well in your hands?
Yeah, I think you highlighted it. I think there's been descriptions about the worries of heterotopic bone or healing across your resection. So you do have to worry about that. I think it's a lot less frequent than it's been written in the literature. I think the technique that I like is to pre-drill it and not necessarily put your screws in yet. So in other words, put your cannulated pins in, or sorry, for cannulated screws, drill it, and then you can maybe put one in and use that as a joystick, and don't put your second one in because you don't want to jeopardize fixation. And then you can use it as a joystick. Now prep your sigmoid notch and ulnar head, and then you can come back and you can find the spots where you need to do the fixation. The one method that I like that it's in the British Journal. I think I reference it in chapters and other places. I'm sure I do. Diego Fernandez described using the FCU for the SK procedure. And I like, we've all been taught how to use the ECU. None of them are great. They're all far away. They obviously don't track with pronation, supination. But as you get more proximal for the stump, the FCU to me is more uniquely oriented to help stabilize an SK stump, not a DRUJ, I'm sorry, not a Darrach resection, but an SK. It's better off. And you can find that in chapters as well as his article. So that's what I prefer for stabilization with a SK.
I'd like to ask the panel as well. So what are your preferences for soft tissue stabilization for Darrach or SK? And do you do this routinely? How about Ilvy? Can we hear from you about this?
So I have to admit that I do it just like Bowers describes, because he's taught me many, many times. So I'm a more hemi-resection person.
Me too.
Which contradicts this whole thing, but again, yeah.
If I could comment, the one thing that I didn't agree with Bill on is I thought he made it much too difficult. If you look at his original drawing, he has like 6 little strips that you kind of move around. And
yeah, no, I've simplified that.
Yeah. So in the Green's operative hand surgery, when I did it, there's 2 things that brought out. One is how to use the capsule through there as an interposition as well as a stabilizer. And I still believe in that. I think it's simple. I think it's strong. And I think it works. The other slight difference I have with his technique, it's not maybe even a difference, but it is a difference with Watson's technique. And that is, I think over resection on a hemi-resection is harmful. I know we all want to get rid of the articular surfaces, but it's going to glide there no matter what. And you don't want stylocarpal impingement, and the more you resect, the more you're going to disrupt the soft tissues. So I think minimize your resection of the ulnar head articular surface, and don't touch the sigmoid notch if you don't have to, and do a nice flap of interposition. And I think there's where I found was, I wouldn't say a home run, but it kind of changed my attitude towards hemi-resection.
I 100% agree. I've definitely looked at some post-op x-rays and I'm like, gosh, did I take anything? But I know I did. And the patient feels better. So yeah, that's a great comment.
I totally agree with that. I do very much a hemi-resection for Darrach as well. But I think Charles Daly had I saw you wanted to say something.
Yeah, I mean, I agree with all those points. I think they're all really exceptional points. And, to fill the Bill Bowers loop, he actually lives here in Charleston.
I know, I actually meant to tell you before. I'm like, I just texted him because he used to spend 6 months.
Yeah, we get to spend a lot of time with him. And I agree with the ulnar translocation sentiments. With a lot of it, I do an SK out of fear more than probably data, I think. But I do have a lot of some people, like the cases Dr. Adams showed, that show up maybe even a little bit later with persistent DRUJ instability and have significant arthrosis and instability. And those people, I think, are the slam dunk SK. There really isn't another great surgery for them when they have both significant arthritis and instability. So, those are the people I'm most often doing SKs in.
Those are all great points. I know we're running short on time, but I just want to address a question from the audience. Dr. Stuart Proper asked the question, ulnar abutment seems less of a problem than ulnar impingement in the matched hemiresections. Is there a way to minimize both? Brian, do you have an answer for that?
You said a matched versus what again?
His question is, ulnar abutment seems less of a problem than ulnar impingement in the matched hemiresections. Is there a way to minimize both? He's asking about matched hemiresections.
Well, that goes back to, the lingo has changed over the years because ulnar impingement, and we used to always be called ulnar abutment syndrome, and that would be ulnocarpal abutment, if you will, impaction. And then there's ulnar impingement and ulnar abutment. So I'm not exactly sure what the question is, but I think I understand it is, if we're talking about basically stylocarpal or distal impingement, or as well as convergence of radial ulnar, I think that what Bill Bowers included in his technique, and I've only had to do it a few times, is you can shorten, I think there's a picture of one of them in Greens from years ago I put in, you can shorten the ulnar head at the same time that you do a hemiresection. It's a little tricky, but it's doable. And so that's how I manage it in a few cases.
I just want to tackle one more question from Landon Reed as well. I was wondering if you can clarify the difference between a hemiresection versus Darrach or SK. Could you explain the difference just for our audience between a hemiresection compared to a Darrach?
Well, I can take it quickly. A hemiresection basically means you're removing part of the ulnar head and not transecting it perpendicular to the long axis of the ulna at the ulnar neck. So when you do a Darrach, the entire ulnar head is removed. When you do a hemiresection, only portion of the articular surface is removed, and the remaining, you hope a lot of the ligament attachments to the styloid and even the fovea are retained.
Yeah, thank you. And I think all of us seem to be leaning more towards a hemiresection than a Darrach, which is a very logical thing. So thank you so much for everybody. I'd like to turn it over to Kyle, who's going to start us off on the second paper.
Great, thanks, Harvey. That was an excellent discussion. We're going to move on to our second paper, which is entitled Long-Term Oral Steroid Use, a Unique Risk Factor in Four-Corner Fusion Compared with Other Risk Salvage Operations. So Dr. Charles Daly is who's the senior author here, is going to present the purpose of the study and how they came up with it. So I'll turn it over to you, Dr. Daly.
Awesome. Thank you, Kyle. You guys can see these slides and hear me okay, I hope.
Yes, we can.
Awesome. And thanks to yourself, Harvey and Angela, for organizing all of this. And of course, Dr. Adams for being here. So this is our study, and thanks to all of my excellent co-authors. Charles Johnson is one of which who's here on the call with us today. And so we sort of embarked on this effort to potentially pile on to the mounting evidence that proximal row carpectomy is probably a little bit better option than four-corner fusion. I think across the board, across the country, we are all probably moving towards loosening our indications for proximal row carpectomy and tightening our indications for four-corner fusion. So there have been a lot of studies supporting that idea. Good long-term outcomes after proximal row carpectomies, even in young patients less than 45, many of whom are males and laborers. The cost is less for proximal row carpectomy than four-corner fusion, obviously, due to implant costs, and better mid to long-term outcomes in wrist arthritis. Biomechanical studies promoting all this idea, and finally systematic reviews and meta-analyses. Along the same sort of line, or in an intersecting line, perhaps, the steroids are a hot topic. And so whether it's injected steroids or short courses of PO steroids around the time of surgery, we're increasingly realizing that short courses of PO steroids probably, at least we haven't been able to demonstrate significant infection risks or other complications, but there probably are statistically significant, although very small, differences in infection risks of hand procedures around the time of injections of corticosteroids or immediately after. And so that's sort of where this paper came from, is four-corner fusion at a particular risk for long in those patients who have been on long-term steroids. And so we looked at proximal all patients in this NSQIP database who underwent proximal row carpectomy, four-corner fusion, total wrist arthroplasty, or total wrist fusion, and got a total of 1,298 patients. You can see here from the data that there was a statistically significant difference in sex with regards to steroid use. Females were more likely to use steroids, to be on chronic steroids. Interestingly, BMI and smoking status were more likely to be present in people who were not using steroids chronically. ASA classification was worse in the steroid group, and operative time was worse in the steroid group. And so, you know, on analyzing the data, a lot of that sort of shook out to be, you know, reasonably similar across each of the procedures that we did. And then in all procedures, there was statistically significant difference in complication rate, and specifically rates of postoperative pneumonia in people who were on steroids. And then steroid use was statistically significant when analyzed with logistic regression for any complication. Then specifically looking at each of these procedures, despite the numbers being relatively low, there was statistically significant increase in infection and any complication in the four-corner group with steroids that was not present in any of the other groups in a statistically significant manner. And so, and that held true in with logistic regression. You know, I think this overall is a study that helps to add on to this data that I think we've all been sort of, you know, taking some heed to, that we should probably be more willing to do proximal row carpectomies in those patients who can reasonably have them. Certainly there are patients who have mid-carpal arthritis or other indications for four-corner fusion where a proximal row carpectomy is just not a reasonable option. But in those people who have the option of having a proximal row carpectomy versus a four-corner fusion, such as, you know, classic slack wrist, the data is just increasingly pointing towards you know, voting for proximal row carpectomy. So I'd love to hear everyone's thoughts, and thank you guys very much for the time and the invite.
Great, that was outstanding. Next, I'm going to welcome Dr. Charles Johnson, who's orthopedic resident and who's on this paper, to share his brief thoughts about how this will affect his practice moving forward.
Hey guys, so thanks for having me as well. I'm Charles Johnson. I'm one of the fifth-year residents at MUSC. I work with Dr. Daly. So, you know, I think in terms of this study and my future practice, I think it certainly adds to my decision-making, especially regarding preoperative risk assessment. As Dr. Daly mentioned, there seems to be a shift towards, you know, proximal row carpectomy over a four-corner fusion in a lot of patients over recent years. And I do think that this study adds to the body of evidence that may support that, you know, proximal row carpectomy potentially over a four-corner fusion, especially with somebody who has medical comorbidities and takes steroids in this case. And I think personally, if I had a patient taking steroids, I'm gonna think long and hard about a four-corner fusion, just kind of knowing the perioperative risk. Certainly if they have mid-carpal arthritis and they need one, then it also guides discussion before surgery, and you talk about risk assessment. So I think at the same time, it's a little bit difficult to kind of figure out, do complications happen from the steroids themselves, or is this sort of the medical comorbidities that these patients come with? And I think sometimes it's hard to separate that. I think I'd like to see it kind of borne out in larger studies too. And I think it's definitely going to be something we think about over time. As we go forward in my future practice, something I definitely want to consider to kind of guide clinical decision-making. So I think this is certainly a good step in that direction.
Great. Thanks for your comments. Dr. Adams, our expert, is up next to share his thoughts about this article. And as the slides are coming up, just to encourage everyone to please feel free to put questions in the chat. We'll try to go through them in our discussion.
So am I up and showing?
Not yet.
Oh, you're kidding. I thought I shared. Uh-oh, this is not good. What did I do wrong? Can you still hear me?
We indeed can still hear you.
Oh man, okay. Give me a second.
Harvey, do you have Dr. Adams' slides? Maybe if you have them, we can bring them up and go through them for him.
Yeah, I can pull it up. If are you getting your slides online, Brian? Almost.
No, I'm not. So if you can do it quick, I think I hit the wrong button, but yeah, I can just say next. What I'd like to, while you're bringing them up, I was going to highlight one more thing is that as we look at this for comorbidities, I couldn't agree more. One of the key statements that's made in this paper is on page 5 in the first full paragraph, about 2/3 the way down. And if I could read it, it says, our study did demonstrate an increased operative time in the steroid group, potentially resulting from challenges in fixation and more complicated deformities in these patients on chronic steroids. The increased time and inherent soft tissue insult may contribute to the infection risk. So I think that's a really key statement is comorbidities along with the challenges for somebody that has greater deformities. And I'd like to kind of expand on that a little bit with some thoughts that I have on four-corner fusion. So I be able to control this, or you do this?
I control it, but can you see
next. Yep, next. Oh, you're not able to, can you move it?
Do you see it?
I do.
Yeah, sorry, we can see your screen. We're looking for advancing the slides.
Who's advancing?
I advanced it, but do you see it moving?
No, but you
Not
haven't
yet.
advanced.
Let me try to share it again.
Let me.
Harvey, I can try also. I have it up.
Yeah,
on
you
my
try.
computer.
Here, let me try it. I got it. Oh,
Yeah.
Okay.
There we go. Okay.
All right.
We're
Great,
ready.
great,
Is this me or you?
I am controlling it, Brian. So tell me when to go.
Next. All right, I was sharing myself. Go. So to me, for four-corner fusion, it's not an easy operation, in my opinion. I think the devil's in the details, and there's lots of ways to make mistakes. And 2 of these have been highlighted, as I said, the comorbidities, as well as it kind of highlights that the operative time increases. And we've all been there trying to do this operation, and we've all struggled a bit. Next. So I like to show all these little balls, right? So what you're looking at preoperatively that I think is very important is the degree of carpal malalignment. Do they have ulnar carpal translation? And what is their preoperative motion? And all of these have been highlighted in papers and discussed. And I'm just going to go through each one very quickly. Intraoperatively, there is a lot of different opinions on the joint prep for fusion, which may also be part of this discussion and this paper on infection. We also have multiple fixation methods. We all have our favorites. Our mentors have taught us different things. And then we can still be burned despite doing things relatively well with hardware impingement. Next. So let's talk about ulnar carpal translation. I can tell you, you are taking away the radial scaphocapitate ligament when you, or at least damaging it when you do a 4-corner fusion in order to get that scaphoid out, because it always comes with it. I've only done 2 or 3 4 corners without removing the scaphoid. And so now you essentially have a longer lever arm that's going to drive this carpus even more ulnar. And some of the worst disasters I've had with 4-corner fusion is in this group. So look at that carefully compared to the other side. And to me, this is a no-brainer not to go there. Next. Preoperative stiffness. There's a lot being discussed in the literature, whether it be the PIP joint, the elbow, the shoulder, the hip, or the wrist. And that is the worst motion going in is the worst, the worse the motion going in is the worse the motion coming out. I don't subscribe to that completely, at least in my interpretation of, for instance, total wrist arthroplasty. Others do. I think what it often foretells is that you have more work to do. You have to make this wrist more flexible and think about the soft tissue management a bit more if they have preoperative stiffness. Next. Carpal malalignment. Here are a lot of fun discussions. So we all know that if it's a visi or dizzy, we're going to try to correct that, get the lunate rotated back under the capitate. This probably does correlate with postoperative range of motion. So if they have a severe visi or dizzy and you correct that, you've tightened the ligaments on the one side where you have to pull the lunate or push the lunate back into its better position. So just be aware of that and counsel your patient on which direction they may lose motion. What's not talked about too much in the older literature, but now is a hot topic, and I think for a good reason, and that is the type 1 versus type 2 lunate. So type 1 lunate, where the capitate's nicely over the top of the lunate, that's an easy, relatively speaking, 4-corner fusion. That's where circular plates got to be popular. Because you can go right where the 4-corner meets, screws are easier to put in, on and on. All the techniques are easier and the prep's easier. When you get to a type 2 lunate, now where the capitate's more perched on the edge of the lunate, this is a much more difficult operation. So we are all originally taught, us dinosaurs, that we have to put this capitate back on top of the lunate. I can tell you when you do that, you remove a lot of the lunate or the capitate or both. You also create a gap between the hamate and the lunate. And then you put bone graft in there. You got more bone, a greater bony bridge to get healing. And so this became trickier. And this is probably where we had a lot of non-unions. Where there's discussion now is, do we really need to change that anatomy lineup? Can we really just can we just ignore it and leave the capitate perched on the ulnar side, the radial side of the lunate? My feeling is it looks bad, but it probably is the better option, especially if you don't have to, if it's a mild type 2. So this is a new thing. If you haven't read it, you can pick on your mentor to see what they kind of think. But to me, this is maybe one of the newer changes. Next. Prep. So when the operation was first talked about, Watson described only removing the dorsal 2/3 of the intercarpal spaces so that you maintain the geometry. Later, people started to highlight. I'm sorry?
There we go.
Okay.
Yeah.
Later, people started to highlight that this may lead to non-unions because, again, we're not really compressing across the native bone. We're really trying to compress across bone graft, and this is already somewhat devascularized area. So, so gradually people have said, all right, let's not do that. Let's go ahead and take off all of the articular surfaces throughout from dorsal to volar. I don't think there's a perfect answer here. I tend over my career, I tended to take more bone, even because the scaphoid was already out of the way. A little bit of intercarpal shortening didn't seem to be a problem. Along with this has been capital lunate fusion. Do we really need to include the, the triquetrum and the hamate? because it just adds more areas that could fail. On the other hand, there's those in the beginning of this operation that said, well, what we really want to help out the fusion by having ingrowth from the triquetrum onto the lunate and therefore better supporting it. I don't think there's ever been any good medical evidence for that. It probably is a reasonable option just to do capital lunate fusion if you don't want to do a four corner. The results have typically been the same in the literature. Next. And then along with this is, what do we do with the triquetrum? If we're going to do just a capital lunate, can we just throw the triquetrum away? Well, that's been popular ever since capital lunate fusion was done as an alternative, but it's kind of forgotten about for a while. And then the Australians, coming from Koala Town, they've really highlighted that they like this procedure much better. They think the results are better. It frees up the loss of motion that we often see with four corner fusions. I think four corner fusions can often have severe wrist stiffness. They claim by removing the triquetrum, their range of motion is much better. I would say that that's true, but I would caution you to be very careful when you take out the triquetrum. You're relying on those ulnocarpal ligaments. They are going to be disrupted. You want them to heal properly. Don't want to create, rob Peter to pay Paul here. You have to be very gentle on extracting the triquetrum. Next. Fixation methods. I've used them all. Probably a lot of you in the audience have seen different uses. Many have gone back to using pins, saying that we don't need to get too fancy. Screws, especially headless screws, have been used. I was one of the earlier users because I was involved with KMI on the spider plate with Peter Weiss when he introduced it. It seemed like it was going to be a panacea, and then we all knew it had a lot of problems. And then subsequently, it's had a resurgence. Staples have been used in this operation for a long time. I remember the Shapiro stapler. It reminded me of like a construction one, and you'd fire it into the wrist, and literally sometimes the wrist would sort of explode into pieces. So now we've come a long way with nitinols, and it's very popular, and I think it can work. I would say whichever one you choose, please go practice in the lab before you go with something that you're not used to, because it is the devil's in the details for these two also. And then don't underestimate dorsal hardware impingement. This can really burn you. Some people say, oh, I always remove the hardware anyway, so I don't worry about impingement. I think that's a minority of people. And the problem with doing that is it's another operation. It's expensive. Any operation in the US is expensive, and it creates more stiffness. Next. So I think it's a good operation. Again, patient selection is always important in any hand surgery, especially at the wrist, in my experience. I think if you know this operation, don't throw it away. I want to tell one other story in 30 seconds. Is many years ago, I spent most of my career at University of Iowa. My senior colleague, Kurt Stiers, was doing PRCs in young patients. And I said, well, we're not supposed to do that. That's crazy. You got to do four corners in those. And he goes, yeah, okay. So I started to hop on the wagon that, yeah. And I said, are we admitting this to anybody in the United States? And he goes, absolutely not. And so we would do these four corners because we had farmers, and they had to go, you told them they're going to be 8 weeks in a cast or 6 weeks. And they shook their head and said, not a chance. And so we started doing PRCs, and we were amazingly surprised in how well they did in the younger group. And then we started to do them in construction workers, and they did all right too. We hid all of this from everybody else because we thought we'd just get, annihilated with criticism. And then lo and behold, Peter Stern, who can always write up anything, and said simpler is better. And here we are with this argument that PRC is not such a bad thing. So we'll see what the next generation says. But I would agree with the comments that this is four corners, a hard operation. I think it's been overrated. It does have problems, but when done well for the right patient, I still think it's a good operation.
Great. That was incredible. Thank you for your expert commentary. I have a question I want to ask Dr. Daly, and I'm going to ask a provocative one after that. I think it's worth pointing out that NISQIP studies really only look at 30 days of postoperative complications. We all know that. That's one of the limitations of the NISQIP database. If you had longer term data, what do you think it would show? You think there would be a difference in non-unions? I mean, that's, I think, a big question for a study like this, particularly looking at steroid use.
Yeah, I mean, you know, I do think so. And I think just, you know, just other studies have similarly shown non-union risk in hardware, the need for hardware removal are higher in four-corner fusion groups with and without steroids. And so there probably is a slightly increased risk of non-union with steroids, similar to sort of the theoretical risk with NSAIDs. Whether it's something we see clinically that's clinically relevant, hard to say. But you know, the early infection risk is probably the highest infection risk. Certainly the first 30 days are going to be the vast majority of infections that you're going to see after any surgery. And so I think that really is going to be the worst of it. There probably would be a slightly higher non-union rate, though. I bet that is true, and probably, you know, hardware removal issues.
The provocative question I wanted to ask everybody, the whole panel, I'll start with Dr. Adams, is how bad does the capitate need to be before you will not consider a proximal row carpectomy?
Yeah, well, there's the other $1 million question, right? So I'm not an, let me start off by saying I am not a capsular interposition guy. And I think that was where people went for a little while, and then they did a 2 or 3 year study and showed it probably didn't matter. The arthritic difference by x-ray anyway was the same as if you didn't put the capsule in there. But maybe they did better clinically. I just don't have any experience with it. I never really believed in it. I thought we'd wear through it in a short time. I often tell my patients I'm going to make an intraoperative decision. I like to get a CT scan when it's questionable. I also, a la Greg Bain, will look in with a scope. I think that can be helpful to basically stage it if you think that's necessary. But if it's just the dorsal third of the capitate, I'm still good to go.
Okay, Charles, any other comments?
Yeah, it's very subjective, and I have done capsular interpositions, and I have the same feeling. I echo Dr. Adams' sentiment that I never really felt great about it, and I don't think it changed anything. But the radiocarpal joint in general, with the exception of the radioscapuloid articulation, is a very forgiving articulation. I think we've seen that from distal radius fractures and everything else. And so I will tolerate a little bit of wear. I've had patients do very well with it.
I think patients like flexion more than we think when they're doing a lot of activities, especially the younger patients. And I think they'll tolerate dorsal damage to the capitate, which they've already sort of been used to anyway for a little while.
We're going to wrap up in just a short while, but I want to ask about AIN and PIN neurectomy. Is that a standard part of your practice for these procedures? Do you do one, both, or neither?
I do both. I think there is some possibly some evidence in the literature that sort of the advent of concomitantly doing anterior and posterior interosseous neurectomies at the same time as proximal carpectomy or four-corner fusion has slightly improved clinical outcomes, and so I do them. Are they a game changer in everybody? Certainly not, but I do routinely do both.
Well, I think it'd be hard to do any of these operations without doing a posterior neurectomy. I don't know how you get it done. So, but I don't do an anterior.
Okay. We do have to wrap up in a moment, but there was a question for one of our hand therapists. Thank you for attending in the audience, but I want to ask about postoperative therapy protocols for both four-corner arthrodesis and proximal row carpectomy. What do you do in your practice? Brian, I'll start with you, and then Charles, and then we're going to wrap up.
Yeah, we only have 30 seconds. So I like to move PRCs pretty early if they're stable on the table, which most of them are. If they're not, it's a tough call. But otherwise, first post-operative visit, they go into a splint and they start moving with active assisted motion. Four corners, it depends on my fixation. If I have solid fixation, it's the same. I'm going to move them early. If I'm worried, if I had a type 2 lunate and I had to do a lot of excess manipulation, I'm going to wait about 4 to 5 weeks before I start getting too aggressive.
Yeah, to Jamie's question about supination and pronation for that matter, I let them supinate and pronate at will in their brace, regardless of the procedure. And obviously aggressive finger range of motion. I agree with Dr. Adams' ideas about proximal rocarpectomy. I'm maybe not as brave at letting them move at 2 weeks, you know, a lot, but I do put them in a removable brace and have them go to therapy and sort of do what they feel is appropriate, which often means taking their brace off half of the time, I think, at home. And then for 4-corner fusions, I tell them, you know, sort of like as if it were a fracture, they're in something, either a brace if I really trust them or a cast if I don't, for 4 to 6 weeks.
Yeah, my PRCs are always wearing a brace while they're during their first month, but they're taking it off a lot. Sorry.
Perfect. Well, we're going to wrap up. Harvey's going to bring up some final slides. And as he does that, I just want to thank everyone for coming this evening. I want to especially thank Dr. Cotterill, Dr. Daly, but in particular, Dr. Adams is our expert for being here this evening. So Harvey, take us away to the finish line here.
Yes. So
Harvey, you're back on
yeah,
mute.
I had a computer issue, but let me run that again. All right. Can you see my slides now?
Not just yet. There we go. Yes.
Okay, great. So yes, please remember to claim CME for hand in focus. And please remember to follow AHS on social media. And finally, our next journal club is going to be an exciting one. We plan for a collaborative journal club with JHS European. This, I think, will be very exciting. It will be a great variation on hand in focus. So thank you again, everybody, for your participation. I'd like to thank our authors, our residents, Dr. Adams, in particular, for our expert for sharing your pearls of wisdom, Carl, and of course, the audience for all your wonderful questions. So thank you so much, everybody. Have a good night, and please join us again for the next edition of Hand in Focus.
Good night.
Good night,
Thanks,
everybody.
everybody.
I guess, thank you very much.
Thank you, everybody.